So normal standardization and speed, and you look at the ECG. The first question is, what will you do? Troponin, coronary angiogram, heparin, and dual antiplatelet drugs. None of the above. Yes. Chest pain, 30 minutes. So you don't want to do anything. More details. A chest pain detail. Nature of pain. Okay. Very good. Very good. So, right, you are none of the above. None of the above. What do you want to know? Nature of chest pain. Okay. Then, any radiation. Okay. Hemodynamics. Good. Hemodynamics. Okay. Unequal pulse. Okay. Okay. Right. Everything is okay. Previous ECG. Okay. All answers are wrong. Family history. Good. All answers are wrong. We have put the standardization and speed in the first ECG itself. Repeat ECG. So why you want to repeat the ECG? To see the evolutionary changes or serial changes. But the repeat ECG is because many of your UR complexes are cut off in V4. So that's why you want to repeat the ECG. You don't see the entire QRS complexes in some leads. So you cannot accept this ECG. The family history, chest pain, அதெல்லாம் முதல்ல ECG ஒழுங்கா ரெக்கார்ட் பண்ணியிருக்காங்கன்னு பார்க்க. This ECG, cut off ECG. V4ல எவ்வளவு QRS இருக்குன்னு தெரியல. So அதுக்காக தான் repeat ECG is most important to know the entire ECG. This is a cut off ECG. So don't ever accept a cut off ECG. Right. Now the ECG is taken fully. So will you accept this ECG?
No, sir.
No, sir. No, sir.
Why no?
Complexes.
Standard is not mentioned.
Anna Rajsekhar?
The complex has gone out, sir.
Complex has gone out. Very good. You are from outside giving the right answer, Rajsekhar.
Thank you, sir.
So outstanding answer from outside. So ECG complexes are going outside. So what will you do? Repeat the electrocardiogram in offset dissection, and when gone out of the ECG, don't know the true voltage, actual low voltage, what is the exact voltage of the QRS, whether there is a left ventricular hypertrophy by a voltage change, you do not know. So you must know entire the voltage criteria to diagnose LVH. That's why you have to record the ECG with off standardization. So that's a primary thing in this ECG. Whenever you look at the ECG and it's cut off, and the ECG complexes are going out of the ECG paper or the measurement area of the ECG paper, you must always make sure that all your ECG complexes are coming into that ECG measurement area, and then you measure the QRS complexes and make sure whether the patient has got a LVH or not. So this is your cutoff ECG, and this is your ECG, which are going out of the ECG paper. Both ECGs are not acceptable for interpretation. Please, whenever you have this type of ECGs, you must make sure that this ECG is should be repeated in off standardization, and also you must get the true voltage of the electrocardiogram. Right. It is Valence syndrome. It is not Valence syndrome. Why? V2, V3, V4. It is not Valence syndrome because the patient is having chest pain now. There is a lateral elevation, lateral ST elevation and T-wave inversion. Patient has got a LVH. All of the above, list not complete. list not complete. So what else you want to know? When I put list not complete, not necessarily that will be the right answer. It is also can be all of the above. Right. So, so every time we put list not complete doesn't mean anything else is there. This is not valence because during the ECG changes, the patient has got chest pain. Valence is not like that. Second, the area of ST elevation and TY inversion is different. Patient has got a significant left ventricular hypertrophy. So there are a lot of conditions which can produce what is known as pseudovalence. So the pseudovalence is LVH is the primary cause of pseudovalence. So because you have a little bit of coving, you have a symmetrical TY inversion LVH, especially in patients with apical hypertrophic cardiomyopathy, you will find large QRS with a symmetrical TY inversion, which the apical cardiomyopathy, the LVH may not be having a classical secondary STT changes. You know the secondary STT changes, the J point is depressed, downsloping ST and a asymmetrical T wave inversion. Whereas in apical cardiomyopathy, it is a typical ischemic T wave like inversion where you have a well-formed horizontal ST, you have a symmetrical T wave inversion, which will mimic a primary T wave inversion. That's what happens in hypertrophic cardiomyopathy. So usually in valence, chest pain is nearly always absent when the ECG is showing the changes. That is a typical of valence. So valence is nothing but an aborted STEMI. The patient would have had 100% occlusion yesterday, and you would have had a spontaneous thrombolysis, which has opened some amount of coronary arteries and little bit of blood flow to the distal myocardium, would have aborted a classical QA infarction, but would have significant ischemia. So it is a spontaneous refusion that results in T wave inversion, and the pain is resolved by this time. But this patient has a chest pain during this ECG changes. That itself is not against, it is against a valence. So valence defines by chest pain and ECG abnormalities. The chest pain is not simultaneous with ECG changes. That's a valence. So many times I told you during valence, if the patient has chest pain, the T wave become normal. The pseudo last time also I showed. A pseudo normalization of T wave will happen when a patient's valence ECG, the patient is having another type of ischemic chest pain. So although acute MI can represent epigastric pain, it is not all common. Not at all common, and T wave inversion in the setting of epigastric pain is not high risk for acute coronary syndrome. The T wave inversion in valence is typically from V2 to V4. So whenever you find a T wave inversion to V3 to V6, especially with a tall QRS, you must always think of left ventricular hypertrophy or apical cardiomyopathy, which is contributing to T wave inversion rather than a typical valence syndrome. So that's why it's called pseudo-valence. This is the true valence actually. There are two types of true valence. The type A valence where you have a little bit of coving and the T wave inversion, and type B valence where there is a typical horizontal ST with a typical T wave inversion. Usually it is confined to V4. This deep T wave inversion will be V2 to V4. Very unlikely you have changes in V5 and V6. Whereas in our electrocardiogram, we find significant changes in V5, V6 and not big changes in V2, V3. So these are our two types of valence, type A and type B. So that's the important differentiating point, and your QRS is normal. In valence, your QRS is normal. In our ECG, the QRS is abnormal. So this is a situation where you have to think of LVH. So having decided that it is not valence, what will you do next? Troponin, echo, both, neither. Patient has got chest pain of 30 minutes, almost severe pain, typical pain.
Echoes. Both, sir.
Both. Right answer will be both. You have to do a troponin as well as echo. So echo in this patient who's got a tall QRS with a deep symmetrical T wave inversion is likely to show what disease? Shamrath disease, Wenckebach disease, Yamaguchi disease, Sangai disease.
Yamaguchi.
Yes. What disease?
Yamaguchi disease.
Yes. What is Yamaguchi disease?
Apical HCM.
It is a classical apical hypertrophic cardiomyopathy. So this is a classical apical hypertrophic cardiomyopathy. Is first described in Japan. So the hypertrophy is predominantly in the apex and it does not produce an LVOT obstruction. If at all, it can produce a mid-ventricular obstruction and not, if at all, it can produce a mid-ventricular obstruction and not the LVOT obstruction. This is a typical ECG. Many times the patient will come for a routine evaluation for a significant ECG changes. This is a classical presentation of apical hypertrophic cardiomyopathy. You would have gone for a master health checkup and the ECG would have taken and they will find a grossly abnormal electrocardiogram. Many times they will advise the patient to get admitted immediately because of the acute coronary syndrome. So this type of recurrent admissions are there. So this is a typical apical hypertrophic with history. So this is one situation where you can have this type of electrocardiogram. So this is a typical, if at all the ECG is going to show in this ECG, you may expect this. You may expect that. What actually patient has got may not be this, but typically in this type of ECG changes, must always do an echo to expect an apical hypertrophic cardiomyopathy plus or minus mid-ventricular obstruction and not LVOT obstruction. So this is a classical apical hypertrophic cardiomyopathy ECG. The important thing about apical hypertrophic cardiomyopathy ECG is that you have a very tall QRS, you have a symmetrical deep T wave inversion, but what is the point to differentiate between a classical primary T wave inversion and a hypertrophic cardiomyopathy T wave inversion is the T wave apex is very sharp in apical cardiomyopathy. Whereas in ischemia, the T wave apex is little blunt. It is not so sharp. So that's why I usually compare it with the hyperkalemia. So our hyperkalemia, you have a tall T wave with a very sharp apex. When you have an inverted T wave with a very sharp apex, especially with a high voltage ECG, it is most often it is with a normal QT. With a normal QT. So when you have a blunt apex with a normal QT with a horizontal ST, it is a primary T wave inversion. Similarly, you have a long splide T wave inversion with a long QT. It is a subarachnoid hemorrhage or cerebrovascular accident where the patient has got large T wave, blunt apex, long QT. Whereas secondary STT changes will have depressed J point, downsloping ST, asymmetrical T wave inversion. So these are the 4 T waves you must always keep in mind. A primary ischemia, secondary T wave inversion, and apical hypertrophic cardiomyopathy T wave inversion, and also the cerebrovascular accident. So all these things produce giant or very deep T wave inversions. Each one of them has got different type of approach and diagnosis. So this is a very typical T wave of hypertrophic cardiomyopathy, where the inverted T wave will have a very sharp apex, just like you have an apex of the T wave in hyperkalemia. So this is how you differentiate an apical cardiomyopathy plus, in contrast to other LVH in hypertension, in aortic stenosis. In all those conditions, you will have classical secondary. The classical secondary T wave inversion, your J point will be depressed and you have a downsloping ST segment and asymmetrical T wave inversion. So that will tell you it is a classical hypertrophy or hypertension or aortic stenosis and not apical hypertrophic cardiomyopathy. So the troponin is 0.125. I am not giving you high sensitive troponin because many of us are not doing in peripheries. You are still doing a regular troponin. So I am giving it's a patient from periphery. So they did a typical troponin or a regular troponin. And the troponin was 0.125 nanogram per ml. Troponin T. This is troponin T. You think the troponin is positive or negative?
Negative.
ஸோ இது வந்து ஒரு 1000 தடவை சொல்லியிருப்போம் நார்மல் வேல்யூஸ் ஃபார் ட்ரெப்போனின் டி. ஸோ ஒவ்வொரு தடவை ட்ரெப்போனின் வேல்யூ காமிக்கும் போதும் ஒவ்வொரு ஆனுவல் ஜென்ரல் பாடி மீட்டிங்லையும் ட்ரெப்போனின் லெவல் என்னன்னு சொல்லிகிட்டே இருப்போம். அடுத்தது ட்ரெப்போனின் லெவல் காமிக்கும் போது அது பாசிட்டிவாக நெகட்டிவான்றது இன்னும் டவுட்டு. லீவ் அலோன் ஹை சென்சிட்டிவ் ட்ரெப்போனின். I am telling you regular troponin which we have been doing for last 10 years and more. Point. Yes, troponin is positive, a good 0.7 and why not 1. Whether you will have troponin I and T values are going to be same or different. They are going to be different. So this is your troponin, regular troponin. With a troponin I less than 0.7 nanogram per ml is normal. For troponin T less than 0.1 nanogram per ml is likely to be normal. Our patient has got more than 0.1. That means it is a troponin positive patient. It is a troponin positive patient with chest pain. So please, at least if you are not able to remember the complexities of 0 hour high sensitivity, 1 hour turnaround, all these complex things, at least remember basic troponin levels. Different kits, you must know what is the different what kit you are using, and you must. So what is the normal value for your kit you are using? You tell me. 0.05. So whatever the kit you are using, you must know what kit you are using and what is the normal level in that particular kit. So please remember that. So this is a regular kit they use, that one of the kits they commonly use kit. So this is usually it is easy to remember 0.1 and 0.7, 0.07 actually. So now the important question is coronary angiogram should be done now. Chest pain, the T wave changes, troponin is positive. Renal failure இருந்தால் coronary angiogram பண்ண மாட்டீங்களா? Excellent. Give Vijay Kumar a very big hand. So he is always at his peak in annual general body meetings only. That means once in a year. Right. It is no. What else you for is actually false positive troponin. His creatinine is 4 milligram. So that's why the troponin T, we cannot be reliable in this patient. So we have to either do a troponin I, or we must look for rising and falling titer. Whereas the secondary troponins purely due to chronic renal disease will remain same. If there is acute coronary syndrome, there is a rise and fall. That will tell you over and above basic things, you have additional acute coronary syndrome. What is important is the serial troponin rise and fall. So that is very important rather than a single value. All right. Patient has got a persistent chest pain. What will you do except?
D-dimer.
D-dimer, okay. Cystatin C. So already creatinine is 4. There is no point in doing cystatin C. Cystatin C is done to detect early kidney disease even before the creatinine is rising. So there is no point in doing cystatin C. Somebody said D-dimer also. So D-dimer also, because this patient had chest pain, breathlessness, people did D-dimer in this patient. Because some amount of chest pain was there. Sometimes breathlessness was not there. There was clear lungs. So people also wanted to rule out other important diagnosis. And they did D-dimer in this patient. And the D-dimer was 13,000. Repeat echo did not show wall motion abnormality. And I always tell you, when the echo is normal, what else you'll do? So I don't want to ask again, and don't want to see your blank faces again. So I have given the answer. So I don't want to put the question again to say if the echo is normal, what else you do? Then you look blank. Then I'll say you must do speckle tracking and global longitudinal staining. So that answer I already given you. So GLS is normal, global longitudinal strain is normal. But the D-dimer is 13,000. What is normal D-dimer value?
less than 50, 500, less than 500 nanograms
nanogram
per
per ml.
500.
The answer is none of the above. It all depends upon this
Wait.
particular diagram. So if you suspect pulmonary embolism, first apply the clinical prediction rule. The clinical prediction rule is showing a pulmonary embolism is likely, you straight away go for imaging. So don't waste time on D-dimer. Your clinical prediction, you know that are certain findings are clinical prediction rule. What is the mnemonics for clinical prediction rule? Anybody remember? Anybody remember? We have told you the clinical prediction rules mnemonic. So ரொம்ப நாள் ஆச்சு homework கொடுத்து. So we'll give a homework and we never get the answer for homework except from Wilson. So hope Wilson will
4 years,
answer.
sir.
Yes?
4 years, sir.
4 yes illa. It will come, it will, in the mnemonic will indicate what pulmonary embolism will produce. So that's a clue.
Basic score.
No. So if your clinical prediction rule is not likely or very low probability or intermediate probability, then you do a D-dimer. Then the D-dimer's positivity depends upon the age. If the patient is more than 50 years, and what is the upper limit is age plus 10. The age plus 10, if the D-dimer is less than age plus 10, then pulmonary embolism is excluded. The patient is 50 and the age plus 10 is your estimated D-dimer is more than age plus 10, then you definitely require imaging. Age into 10, that's what, age into 10. So age into 10, so depends upon the age, you have to apply this formula. So if the patient is less than 50 years, then only your 500 nanogram rule. It is not for all patients the 500 nanogram rule. So less than 50, 500 nanogram, less than that, P excluded, more than 500, you can go for imaging. So please remember D-dimer, the approach to D-dimer is first clinical prediction rule. If it is clinical prediction rule is indicating pulmonary embolism, straight away go for imaging. And when it is uncertain, depending upon the age, you fix up the target D-dimer beyond which you are going to diagnose pulmonary embolism. So it is not 500 for everybody. Our patient has got a D-dimer of 13,000. So repeat echo, what you must see then?
McDonald's.
Mecanol sign. You will not see D-shaped LV, you will not see pulmonary hypertension.
Early to appear as
All the three. So repeat echo, you must see all the three if you suspect pulmonary embolism in this patient. And ECG, is it for pulmonary embolism? No sinus tachycardia. Very good. Vijay Kumar is at its peak now. So I think every week we'll tell Vijay Kumar this is annual general body meeting. Then only you come to the limelight. So please, Dr. Ramesh, tell each before each meeting, tell Vijay Kumar it is annual general body meeting. So this is ECG is not like, but anyway, I have asked question about in this ECG, we are not, repeat ECG, we are not going to see all that because the D-dimer is also elevated, but it is unlikely to be pulmonary embolism. Anyway, because I put Mecanol sign, I just want to tell you what is Mecanol sign. Mecanol sign is related to the RV, LV, both, neither.
RV.
What is
RV.
Mecanol sign?
RV.
RV.
RV,
What you are going to see in RV?
apical.
Apical?
Hyperkinesis.
Yes, madam. Apical. You are right. Apical.
Hyperkinesis with free wall hyperkinesia.
Excellent. So the answer is the both. So we will always forget what will happen to LV in Mecanol sign. So the Mecanol sign is a very typical selective akinesia or dyskinesia of LV, RV. In all the other pulmonary hypertensions, there is a global hypokinesia of RV. Only in pulmonary embolism, there is a apex will be hypercontractile, only RV free wall will be hypocontractile. That is very typical of pulmonary embolism produced by pulmonary embolism. Please remember your LV is also hyperkinetic. LV apex is hyperkinetic. So it is not only RV, it is also LV. So LV hyperkinetic and these three important signs. So normal RV apex is tethered to LV. That's why it is hypercontractile. Why the RV apex is hypercontractile is tethered to LV, which is hypercontractile. That's why it doesn't have significant dyskinesia, and only the RV free wall will be akinetic or a dyskinetic. So that is Meconal sign. So the classical important thing you have to diagnose when Meconal sign is present. Along with that, you have a large LV which produces a D-shaped, large RV which produces a D-shaped LV, and you have a significant pulmonary hypertension. You must suspect a pulmonary embolism. So first answer is that none of the above is for this question, that you are not going to do none of the above. You are going to do none of the above. So just we discussed about Meconal sign incidentally. And when you answer none of the above, that is not Meconal sign, not a D-shaped LV, and not pulmonary hypertension. So none of the above you are going to look at in echocardiography. So what else you will look at for an echocardiography? When your D dimer is positive. Vegetations, good.
Dilated,
Yes?
the dilated RVRV, paradoxical septal motion.
Paradoxical septal motion or this, I told you, there is LV is no regional wall motion abnormality, GLS is normal, RV is normal, D dimer is significantly elevated, patient has got severe chest pain. When you do echo, you always think it is left ventricle, right ventricle, mitral valve, tricuspid valve. You forget there is a great artery which is arising from the ventricle. So you'll always image an aorta when there is chest pain. Please don't forget that. So aorta is part and parcel of your echocardiography examination. We always look inside the heart and not outside the heart. Many times acute chest pains are due to outside the heart and not inside the heart. And because of the ECG changes, you will be actually misdirected in your approach and the management, and the patient typically showed aortic dissection with a significant aortic regurgitation. So D dimer elevation is not exclusive right of pulmonary embolism. D dimer will be increased whenever your coagulation is increased. Whenever your coagulation is increased, it is the body's response to produce a D dimer, which is the fibrinolytic end product. So that means your coagulation is increased, or endogenous fibrinolysis is increased, and the D dimer is a fibrin degradation product. So whenever may be useful in ruling out acute dissection, similar to pulmonary embolism in the first 24 hours after the symptom onset, and for ruling out acute conditions with high rates of coagulation activation. Please remember, in acute dissection also there is a high rate of coagulation activation. So that automatically produces increase in D dimer. So in the first 6 hours especially from the symptom onset compared with other conditions like ischemic heart disease. So the D dimer is abnormal when there is acute severe chest pain and back pain, suspect dissection. When the D dimer is abnormal, when the patient has got acute breathlessness and chest pain is minimal with a clear lungs, suspect pulmonary embolism. So that's why it is always should be remembered when you have a doubt about dissection, you not only do a troponin may be positive in ischemic heart disease also, But D-dimer is unlikely to be positive in your ischemic heart disease. When the patient has got a chest pain and your D-dimer is positive, the important thing to suspect is acute dissection. But important thing about this is your turnaround time will be very quick. When you send D-dimer, the D-dimer report will come tomorrow. Right? So when you send a D-dimer or troponin in an acute situation, you expect, or a BNP, in an acute situation, what is very important is the lab's turnaround time should be very quick. They must be able to give you the values as soon as possible, because these are the values which will decide the basic question: heart failure, acute coronary syndrome, as well as dissection or pulmonary embolism. All these things are going to be decided by this particular investigation. So the labs cannot take a routine investigation like this and have a turnaround time of 3 to 4 hours, where you lose a valuable time of treating these conditions. Many times, by the time the result is coming, the patient may not be there. So that's why you have to instruct the lab. This is a situation, your turnaround time will be very quick for this investigation. So they have to stop all the other investigation. They must be able to do that and give you the investigations correctly and quickly. Correctly and quickly. Both are important. And it is a very rarity in many of the labs. So this patient's CT angiogram showed a very typical, you can see the intimal flaps and double barrel aorta, a typical dissection going on in the ascending aorta, so which proven that this patient had a typical aortic dissection. So this is a slide I used to show many times, but anyway, I'm not tired of showing this slide, and our ECG club members would have seen this slide for many, many times, and many, many times they would have forgotten. So the important clinical clues for diagnosing dissection when the patient comes with acute chest pain, which will also mimic an acute coronary syndrome chest pain. The patient also can have an ST elevation because the dissection is extending into the coronary arteries. So ST elevation is acute chest pain. You have all the tendency to do a thrombolysis for this patient or send the patient for a coronary angiogram rather than an aortogram or something. So very important clinical pointers are, when compared to ischemic pain, acute dissection pain is the dramatic onset and you have the maximum pain at the first second itself. Whereas ischemic pain will build over years, just like your subarachnoid hemorrhage, headache, thunderclap headache. This is a thunderclap chest pain. Thunderclap headache is subarachnoid hemorrhage. Thunderclap chest pain is dissection. First minute itself, maximum pain. Basically, the character of the pain is tearing or stabbing, can stimulate acute myocardial infarction if there is a dissection into the coronary arteries, but predominantly you have a back pain. And it may radiate to neck, shoulders, and abdomen and below umbilicus. No ischemic pain will radiate below umbilicus. If the pain radiates below umbilicus, definitely it is going to be dissection. And of course, the MI, if it is a coronary arteries are involved, and if you auscultate, there is some murmur of aortic regurgitation. And the most important thing is asymmetry of pulses because of the dissection. And when you have a predisposing patient with a severe hypertension, Marfan syndrome. So I used to say that any acute chest pain with ST elevation, you must apply these 3 or 4 clinical rules. Until this, otherwise you will miss a dissection. So any acute chest pain, you must see immediately where the chest pain is, whether it is a dramatic onset of chest pain. You must immediately see where the maximum chest pain. You must always look at where is radiating, and you must always look at the asymmetry of pulses, auscultate for aortic regurgitation. When these things are present in the patient with acute ST elevation, stop a minute, don't thrombolyze these patients. When these clinical features are there with the ST elevation, don't thrombolyze the patient. Wait for a minute, have a CT, rule out dissection, then only you must thrombolyze the patient, because thrombolysis is contraindicated in acute dissection. Already bleeding is happening in the false channel. When you thrombolyze this patient, there is a significant bleeding which will happen into the aorta, false lumen, and also into the pleural cavity, and will produce enormous danger to the patient. So the learning point from this ECG is important to recognize First of all, pseudo infarct patterns, because many times we jump up to valence sign because diagnosing valence sign is a prestige. If you diagnose valence sign, you think you are a ECG boss, then you are diagnosing valence sign. So you will have always a tendency and temptation to diagnose valence sign. But there are certain points where there is a pseudo valence sign. And because if you do unnecessary valence, you will activate the cath lab and you don't recognize it, you will have a diagnostic momentum towards a wrong diagnosis of acute coronary syndrome rather than the true diagnosis of acute dissection, which both of them will have a different area of approach. The one treatment is contraindicated in the other treatment options. So that is a very important learning point. The other learning point is any acute chest pain, do echo when ECG is doubtful. In echo, don't look the heart alone. Look at the aorta, look at the pericardium, look at the right ventricle. All these things are important. Troponin indicates a myocardial injury and not the etiology. Any injury produced by the myocardium, myocarditis, heart failure, a chronic coronary disease, anything produce a troponin elevation. But the etiology of injury, whether it's a coronary heart disease, that is the one you have to establish. Not automatically all troponin elevations are acute coronary syndromes. So any myocardial injury will increase troponin. A secondary troponin elevation due to a chronic cause like heart failure or a chronic kidney disease will be stable throughout. If it is acute coronary syndrome, you will find the dynamic rise and fall of troponin. LVH can produce pseudovalence. Carefully look where is your ST and T wave changes, and carefully look at the peak of the T wave. Carefully look at the LVH for the voltage criteria of QRS. So as I told you, when you treat acute dissection, acute coronary syndrome, it is going to be very harmful. Don't accept all your cutoff ECGs as well as ECG going beyond the baselines or the ECG paper. Repeat ECG in half standardization and to get the full magnitude of QRS voltage, then only you can diagnose a hypertrophy or hypertrophy or enlargement by applying the voltage criteria. So these are the learning point from the simple ECG, which looks very simple, but it is a ECG which actually will mislead you in many times if you are not careful in your clinical approach, if you are not careful about the investigations like D-dimer, which can also get elevated in acute dissection. Because when we say D-dimer, the only diagnosis which will come to your mind is pulmonary embolism. Always sex is a pulmonary embolism. But this is another important condition which can increase D-dimer enormously is acute dissection. So that's the ECG about. So any questions? Acute dissection in pregnancy is a very dangerous situation. Usually the dissection in pregnancy is most often Marfan syndrome. So that's why in a Marfan syndrome, beyond a particular root dilatation, the pregnancy is contraindicated. So that's why the most common cause of dissection in pregnancy is Marfan's and aortic root dilatation. Second important cause of dissection will be a bicuspid aortic valve with aortic root disease. Many times bicuspid aortic valve, the valve may be not stenotic or non-regurgitant, but the problem will be aortic root degeneration because of the medial degeneration of the aorta. Aorta will be large. So that's why bicuspid aortic valve with aortic dilatation or Marfan syndrome with aortic dilatation, the pregnancy is contraindicated. So you have to actually prevent dissection in pregnancy. Anything else? Joseph, you want to add something? Exactly. Okay.
Will give you a better specific reports.
Exactly. But the availability of troponin I is not so easily done in many labs. They do troponin T more often than troponin I.
No, sir. Troponin is also specific also. Troponin T is present in muscle
Exactly,
also.
exactly. Troponin I is more specific and it's also reliable in chronic kidney disease. So it is preferable to do troponin I rather than troponin T if it is available and your lab is able to give you quantitative measures at a very quick time.
This is called as triple test in ER, sir.
Yes, yes, that's what CT angio will rule out coronary disease, dissection and pulmonary embolism.
Triple test.
Triple rule out.
Triple biochemical test.
Triple
is
biochemical.
D-dimer, troponin with BNP.
BNP, yeah.
Sir,
Yes, Raj Sekhar.
the post-cardiac arrest patient, recently I had one patient, I remember that, but that patient D-dimer was about 13,000. Where a post-cardiac event also can precipitate the increase in D-dimer.
So D-dimer can be elevated in any situation where your coagulation system gets activated. So for example, your cardiac arrest is a situation where the cardiac arrest is because of coagulation system activation, then the D-dimer may be elevated. So any situation where coagulation system get activated, the endogenous fibrinolytic system get activated. So actually, it is a very peculiar situation where we diagnose a particular disease not by the parameter produced by the disease. We are diagnosing a disease by the counter-effective measures or actually which is the counter-effective measures for that particular disease. We are diagnosing with that. So we are diagnosing not by the biochemical parameter produced by the disease. For example, if you have myocardial infarction, the infarct muscle produce troponin, you diagnose myocardial infarction with the troponin. Whereas here, it is a compensatory mechanism, is your D-dimer. So we diagnose a disease because the compensatory mechanism is elevated, not by the disease per se. And what is the other situation? We decide by compensatory mechanism.
Actually, this patient came with fever, sir.
Right.
Fever, vomiting, giddiness, and suddenly went for a cardiac arrest. This is the norm.
So maybe it's a fever, patient would have been bedridden, and a pulmonary embolism is a possibility in that patient, a sudden cardiac arrest in that patient. So what is the other disease where you diagnose by compensating mechanism and not the biochemical parameter produced by the disease itself? Heart failure. In heart failure, you diagnose by natriuretic peptides. Natriuretic peptides are compensating mechanism for heart failure. Because the compensating mechanism is increased, you think the heart failure is happening. Because now your endogenous coagulation system, endogenous fibrinolysis is increased, indirectly you think your coagulation system is get activated. So these are the two diseases we diagnose, not by the biochemical parameter produced by the disease, but by the compensatory mechanism. So that is a peculiarity of D-dimer and BNP. Right.
Sir,
Any
one
more
question,
doubts?
sir.
Any more
Yes,
doubts?
sir.
Yes.
சார் இப்போ அந்த பேஷண்ட்டுக்கு கிரியாட்டினின் அதிகமா இருந்ததுன்னா ஆன்ஜியோ பண்ண முடியாதுன்னு சொன்னீங்க சார். அந்த மாதிரி பேஷண்ட் என்ன பண்ணி
ஆன்ஜியோ பண்ணக்கூடாதுன்னு இல்லை. ஐ திங்க் ஜோசப் யூ கேன் த்ரோ லைட் ஆன் how you do angio in patients who are elevated creatinine so that they will know. It is not as if it's an absolute contraindication. It's all relative risk versus the benefit you are getting. The patient has got a massive MI and is going to die of massive MI. You always take precautions and do all the precautions of doing a safe diet or dehydrate the patient and do N-acetylcysteine and also give. So a lot of corrective measures are there. You can keep the nephrology by the side. It all depends upon the risk versus benefit. So when you have a massive MI and your creatinine rise, you cannot say, because the creatinine rise, I will not do echo and do a PCI. So there it is a life-saving procedure. Let the patient live and develop a heart renal failure, then we manage it.
Yes, sir.
Rather than allowing the patient to die of myocardial infarction. Is it right, Joseph? So there are a lot of precautions now they do. So they're no longer afraid of having a coronary angiogram done in patients with the elevated creatinine. So now we have a little bit of safer dice. We have what to do, how to hydrate the patient. Hydration is most important. How to follow the patient after angio. So all these things are there. So definitely it is not absolute contraindication. For example, if it is a 50-50 indication to angio, you may hesitate to do angio at that point in time. So you can stabilize, get a nephrologist's opinion and do. But when the patient comes a massive MI, an acute MI with a elevated creatinine, so don't wait, just do and take precautions. And if the patient worsens, of course, the nephrologist is there, the dialysis is there, we can always get things under control after saving the patient's life.
Thank you, sir.
Thank you. Any more questions from the online members? Right. Okay.
There is in the chat box, sir.
Chat box.
Yeah, sir.
Okay.
Good questions in the chat box.
I will see.
So mechanism of S1, Q3, T3 and
The
Prop-
mechanism of S1, Q3 and T3, although it is a very popular sign, but it is not a common sign for a pulmonary embolism. So pulmonary embolism, the common sign is a T wave inversion V2 to V3. That is the most dangerous sign and it is the most common sign. Because the V1 to V3 T wave inversion tells you that the RV is ischemic and the RV is enlarged and it is occupying more of septal area. It is pushing the septum towards left side and it is RV is occupying V3, V4 area and it is ischemic. When it is ischemic, that means it is facing an enormous resistance in pulmonary circulation. That's the most common and it is a sign once again mistaken for valence. When you have a symmetrical T wave inversion V2, V3, V4, you always think of valence. But pulmonary embolism produces similar symmetrical deep T wave inversion. One differentiating point is that this patient will come with breathlessness. That patient come with chest pain yesterday. And when he take ECG during valence, he will not have anything at all. That is a typical of valence. During valence ECG, there is no pain at all. The second important ECG sign is when you have a T wave inversion in L3, along with T wave inversion V1 to V3, you must suspect a pulmonary embolism. Because in the pulmonary embolism, the right side, L3 will show T wave inversion because it is representing right. So a valence like ECG, chest pain is there. T wave in L3 is normal. It is a typical valence. Patient has got a breathlessness. T wave is inverted. Along with the V1 to V3 and V4, along with the T wave inversion also L3 is inverted. Then it is likely to be a pulmonary embolism. That's a common sign. So although S1, S2, S3 tells you that the terminal vector is, S1, S2, S3 is terminal vector. The endo vector will be going towards AVR in pulmonary embolism. So when the terminal vector goes away from these leads, L1, L3 and Q3, T3. So because Q3, L3 represent RV. When the RV is undergoing ischemia, it will show some sort of Q wave and a T wave inversion. The S wave in L1 tells you that's a type of right bundle branch block. Because of the right bundle branch block or strained LV, the late activation is right ventricle. So that's what the S wave in L1 represents, the late activation or LV enlargement and acute onset of right bundle branch block. Your Q3 and L3 T wave inversion tells you that the patient's RV is ischemic and RV is undergoing some sort of strain. That is the basis of S1, Q3, T3 sign. But also it's well talked about sign. It is not a very common sign. So don't expect, what you must see in an acute pulmonary embolism is the T wave inversion. V1 to V4, although some patient may not have a right axis deviation at this point in time. But what you carefully look will be the T wave inversion in L3. But the presentation is different. This is chest pain. The valence, there is no symptom at all during the ECG changes. Whereas in a pulmonary embolism, patient will be dyspneic at the time of ECG changes. A cause of elevated troponin in CKD is troponin is excreted by kidney, whereas troponin I is not. So that's why the troponin get elevated even without myocardial injury in CKD. So that is a mechanism.
Sir, excuse me.
Troponin use in preoperative evaluation we do not routinely do unless you have suspecting some sort of fresh ECG changes. There is no routine evaluation. Routine evaluation is not needed in a troponin I in a preoperative situation.
Yes, sir. Sir, regarding troponin I is low molecular weight protein, sir.
Yes.
When compared to troponin T.
Yes.
That is why in all CKD patients it is easily excreted.
Yes.
Whereas in troponin T, it is a high molecular weight protein, it is not excreted. That is why it is high in CKD patients.
Exactly.
Thank you, sir.
So that's what. The mechanism of why it is elevated in CKD, why it is not excreted is the explanation given by Dr. Wales. Right. So any more questions? Rhabdomyolysis. That also will increase troponin T because troponin T is little bit non-specific when compared to troponin I. The specificity of troponin is very high. Right. Then we go to the, so unfortunately or fortunately, we will not have the lecture today. So many people think it is fortunate. So we will not have the lecture today. So we'll hope for annual general body meeting. And I know some of the people are very happy there is no lecture today. But some people are unhappy also there is no lecture today because they cannot sleep. Right. So we'll invite our Secretary General, Dr. Ramesh, Vice Chairman, Dr. Dominic, to the dais, Treasurer, Secretary, Girigiri, Treasurer Sukumar. We'll just go through the proceedings very quickly so that this is actually legal requirement or statutory requirement for any registered society to do all this. So we have to do this every 1 year. So I thank you for coming. And I am supposed to give a welcome address. So I thank you for coming to this annual general body meeting of அங்கே வந்தே கொடுக்கலாமா எங்கேருந்து கொடுத்தா வெல்கம் கிடையாது அங்கேருந்து கொடுத்தா வாங்க டாமினிக். So I also I have great pleasure in welcoming you all to the annual general body meeting. So as I told you, this is our legal requirement to run the society. So we have to go through some of the agendas of this report. So we look back the last year, what we have done and what we have not done and what we must do in the next year. And all this with reports which will be presented to you by our Secretary General as well as our Treasurer. So I'm very happy that this type of hybrid meetings, maybe we may be conducting very often next year. We thought we'll conduct some of the hybrid meetings because why we are not conducting hybrid meetings is because of the lot of technology involved. So all these things must go correctly so that our online club members, now the online members have become very huge in number. So Secretary General will tell you what is the membership number this year. So it is very difficult to reach them in thought of this type of meetings. So that's why we like to do online meetings. So I hope you all enjoyed the dinner, and I'll welcome our Secretary General, Dr. Ramesh, to give the welcome address. And before he give the welcome address, it's my honor to facilitate him because he has been just selected the honorary professor of IMA, National IMA. Just it's actually it's a pleasure and also it is a great privilege of our club to be selected as a national professor of IMA. And he is going to receive the award. So you are don't make me older. I am younger to you. So don't make me older. Right. So don't make me older in front of the crowd. Right. So he is going to receive the award of 18th in Delhi, New Delhi, in IMA headquarters. So we're all happy, and it is a proud moment of our ECG and Echo Club of Trichy to have you honorary professor of IMA. So from today, we will call you as professor and not Dr. Ramesh, isn't it? So Dr. Ramesh for Secretary's report.
Thank you, sir. Whatever I am today is because of you, sir. Nothing other than that. You only molded me as a teacher, sir. Thanks a lot. So, good evening, friends. Let me just read that. I, Dr. R. Ramesh, as the Secretary General of ECG and Echo Club of Trichy, have great pleasure in presenting this annual report of activities of our club for the year 22 to 23 during this 28th annual general body meeting on this day, the 2nd of November 23 at Hotel Oxina,
Audio,
Trichy. People online are able to see that, sir? Transmitter, the online. Wait, okay. Actually, ECG and Echo Club of Trichy was founded in the year 1995 with just about 20 members initially, and today it has grown to a strength of 227. 225 was when I typed it. Just now another 2 members have joined, right? So current strength is 227. We have members all over from Tamil Nadu, not only from all over Tamil Nadu, but also we have members from other states. We have members from Kerala, Gujarat, Pondicherry, Punjab, Telangana, and UP also. No, it's a real prestigious academic club we have, and our academic year starts from 1st of October every year. I feel really proud to say that this club is one of the most successful academic bodies in many aspects. From the day of inception, without a single default, I mean it, without a single default, we have been conducting meetings on every Thursday from 9:30 p.m. to 11:30 to 12 o'clock midnight. This was not stopped even during COVID times. Since our members are spread all over India, we resorted to online classes since a few years. Still, previously we had only direct classes. Because we have members from all over India, we had to resort to online classes to help them also since a few years. We have also periodically held direct classes as in a hybrid mode like this. We have 3 mottos. The 3 mottos of our ECG and Echo Club are educating the doctor and the paramedics, educating the public, and helping the needy. Our club has performed extremely well in all these 3 areas and has fulfilled its goals and commitments this year also, as has been doing consistently all these years. Appappa kai thattanum. The first motto, the educating doctors and paramedics. We have conducted meetings on all the 52 Thursdays of this academic year. We have discussed 52 interesting ECGs, heard 52 interesting lectures on various topics in cardiology. Some of them were interactive format also. Every meeting was well attended by our members with a good interactions at the end of the lectures. Apart from our chairman, Dr. Jenyapan sir, some of our members like Dr. Dominic, Dr. Kadar, Dr. Vijay Shekhar, Dr. Muttumani, Dr. Vijay Kumar, and myself too have also contributed to the academic activities of the club. Our club has conducted basic ECG course for 3 batches of students this year, each batch consisting of about 100 students. That is more than 300 students we have trained last year alone in the basic ECG. We conducted a fellowship certificate course in the echocardiography on behalf of the National IMA CGP and trained 54 doctors last year and trained them in practice of echocardiography. We celebrated the birthday of founder of ECG, Dr. Willem Einthoven, on 21st May 2023 this year also. And we take pride that for the first time in the history, the World ECG Day came into existence last year because of us only. Previously, it was not there. We would be celebrating this World ECG Day every year on the 21st of May in a fitting manner in future also. Our club members conducted a ECG workshop to the delegates of Clinicon 23, a conference in which about 300 delegates actually participated. This interactive ECG workshop program was conducted in 10 different stations with 10 faculties, which received a very good applause from the delegates. We conducted a workshop for paramedics by teaching the basics of ECG and giving them hands-on training on how to record the ECG correctly and identifying the dangerous ECG patterns. Our chairman conducted several one-day ECG workshops in different medical colleges and has given countless number of lectures in various forms. Just to list a few, some of the ECG workshops we conducted were Ramachandra Medical College, Sri Karpaka Vinayaka Medical College, Tirunelveli Medical College, SR Medical College, MGR Medical University, Arunai Medical College, Pondicherry IMA, Madras Medical College, Melmaruthur Medical College, Thiruvarur Medical College, Chengalpet Medical College, Kadalur IMA, Manakula Vinayagar Medical College, Madurai, name any medical college, he would have given one full day ECG workshop in this year alone. And not only that, he has conducted routine monthly PG classes in KAP Medical College, which was terribly admired by everybody. And we conducted a very unique conference, that is the Confusions in Cardiology, a path-breaking one, was conducted on the 1st of October 23 at the Hotel Courtyard by Marriott. There were a lot of unique features in this conference. One is, all the speakers were from our own ECG club, our own parent club only, who delivered excellent lectures on par with any well-known speaker in the field. We dispensed with all the routine formalities of any conference, like the inauguration function, having 2 chairpersons for each talk, exchanging mementos, elaborate speaker introduction, all those things were dispensed with. By that, we maintained the program absolutely on time. We received 75 registrations within 5 hours of releasing the official brochure. That's it's a record by itself. And we reached our target of 250 within 4 days of release of the brochure. We had to reopen the registrations again due to the heavy demand and the pressures from various quarters, and we extended by another 100. Unfortunately, we had to turn down a lot of delegates due to the limited seating capacity of the hall. This, I feel, is a unique record by itself, which doesn't happen in many other conferences. It's a prestige and honor for our club that more and more members are becoming popular, invited speakers in many forums. Thanks to our chairman for grooming us so well and to follow his footsteps. In this way, we are trying to achieve our 4th new goal of creating great teachers. That's the new goal from this year, that to create more teachers. We place on record our appreciations to the entire core committee who organized this conference flawlessly and all the speakers who delivered excellent lectures. We have reprinted our ECG Ignited book with some modifications, and it's a hot-selling book in any conference today. We have just started a YouTube channel, and soon you can find a lot of educational material lectures, both for the doctors as well as for the public. We conduct regular meetings of the trustees every 3 months to guide the club activities. And our public education program, our chairman has given a lot of public talk on Idayathirku Iniyavai by our chairman in the Srinivasan Medical College, in the Pudukkottai IMA, recently in the Apollo Hospital Trichy, Rotary Club of Trichy 4, and he also gave a Nerukku Ner program in the Vasantha Adaipu in the All India Radio. This is just to list a few of the public education programs. And our charity, our 3rd motto. We have spent rupees 19,79,084 rupees so far this year alone from the Heart Care Fund for helping the needy. We have adopted more than 100 deserving patients so far, and we are helping them with a complete medical care. And all our ECG members and did ECG absolutely free for their patients on the World ECG Day. That's how we celebrate every year. May 21st, no ECG charges for all our patients. Last year alone, more than 500 people were benefited. And our future plans for the next year, in addition to whatever we are doing right now, are to publish a book on practical tips in cardiology, edition 2, right? And then publish a book on ECG excursions, publish a book on ECG eponyms, to continue all the decades-old existing programs of the club, to conduct one major conference like last year, and to celebrate ECG World ECG Day on every May 21st. These are our future plans. And some of the achievements of some of our members. Dr. Mutthumani has been elected as the Secretary of Diabetic Club of Trichy. It's a prestigious club. And he just recently completed his secretaryship of Trichy API also. Dr. Anita was still recently the president of API Trichy. She, along with the secretary Dr. Mutthumani, organized the Apical meet very successfully in a very commendable manner. It became All India popular meet. Dr. Shivakumar received the Service Excellence Award from our sir on the World Heart Day. Dr. Ramesh, myself, Dr. Jayashree Ramesh, my better half, and Dr. Vijay Kumar continue to be the core faculties in the family medicine course conducted by the National IMA CGP. Dr. Chedian is promoted as the Joint Director of Medical Services. Congratulations. Dr. Vela Idraj received Maruthuva Nakshatram Award from Hindu. Dr. Rajashekar of E Road was conferred with the Lifetime Achievement Award for his contribution in the respiratory medicine. Dr. Vignesh is elected as the Secretary of ISA Critical Care Society of Trichy. Dr. Vijay Shekhar was awarded Emerging Leader in Asia Pacific Heart Rhythm Society in Hong Kong and also received the Best Paper Award in the World Pacing Series at Morocco. Dr. Joseph was awarded the Fellow of Sky and is recognized as one of the few to implant more than 1,000 cardiac devices. Congratulations, sir. Many of our members have presented papers and given lectures in the state and national level conferences. Our hearty congratulations to all of them. To conclude, we hereby express our heartfelt thanks to all the trustees, office bearers, and all the members who continue to support and encourage us actively. Our special thanks to Ascot Pharmaceuticals who sponsored all the basic ECG courses and the Sun Pharma who donated liberally for our annual conferences. To conclude, we are proud to say that we have successfully implemented all the 3 mottos of our club this year also, and we are opening another 4th motto from this year. So we are very hopeful that the next year would also be even more fruitful and eventful than this year with the sustained cooperation of you all. Thank you so much. This report will be posted in our WhatsApp group tomorrow to everyone so that you can go through that at your leisure. Thank you so much. Thank you. Next agenda is our treasurer's report by Dr. Sivakumar.
Good evening to all. It's a great pleasure to present the annual treasurer report in front of our chairman and managing trustee, Dr. Chennapan sir, and my dear other office members and other members. As you know very well, our academic starts from the October to September. Our opening balance as on 12/10/22 is 3,38,653. Income from October 22 to September 23 is 22,46,436 rupees. Expenses from October 22 to September 23, 22 lakhs and 72,408. Closing balance as on 22nd September 23 is 3,21,632 rupees. And also I extend our thanks to the following members for their generous contribution towards the noble cause. Sun Pharma 4 lakhs, Dr. Rajshekhar Erode 1 lakh, and Dr. Ilongovan Pondicherry 1 lakh, and Dr. Satish Kumar Bathalagundu 10,000. Apart from this, Ascot Pharma sponsored all the basic classes. Our special thanks to Mr. Suresh. As per the government norms, 80% of our donations received have been spent. So there is no tax issue for us. The details are given in a hard copy. Thank you.
So it is official duty of us to spend almost 80% or 85% of our income every year, what we receive. So that's we've been consistently doing the spending actually. So the important thing about I want to tell in a closed group meeting is that so we don't sell books actually. We don't get the delicate fees. We don't get the annual subscription from you. This is not annual subscription. This is not a book selling. This is not delicate fees. Everything is donation to ECG Club. By donating ECG Club, you become the member of ECG Club. By contributing to the ECG Club as donation, you attend a conference. By giving donation to the ECG Club, you get the ECG book. So because this is not, we are not supposed to go into a commercial activity of selling something and also going for income-based generation of the fund. That's why, so it's all donation. That's why if you buy a book, you will receive the receipt as donation. You will attend a conference, you will receive as a donation. So that's what we've been doing that. So people who donate for the ECG club get the book free. Actually, it means that. So people people pay some amount of money to the ECG club, they attend the conference free. If you give some amount of money to the ECG club, you become the ECG club of the member for that year. So this is what we are doing, so that it may not invite tax headache to us. So that's why you have to maintain that we are not buying the book, we are not paying a subscription, we are not paying the delegate fees for the conference. That's what we are doing until this time. And that's why we are trying to not, because if you sell a book, then all the GSTs, all these problems will come in. So that's why we don't even put the price of the book in our ECG club. You find no price in that ECG book. So it is given free actually for people who are donating some amount of money. So each one of them has got some amount of money to be donated to the club. So whatever the activity is given free. So the next agenda is Vice Chairman Dr. Dominic will give a few words. So we will not have an annual general body meeting without Dr. Dominic's words of wisdom.
Thank you, sir. Respected sir, respected secretaries, and treasurer, and dear friends. Thank you for this opportunity, sir, to speak. And as Dr. Ramesh said, elaborated in our annual report, like we have been succeeding in fulfilling our mottos and then moving on to greater achievements over the last 28 years. And what is striking is that it has been a movement which started with education, and the movement it's a continuous force. It's like an unstoppable, even when COVID could not stop it. It is an unstoppable force of learning and a gathering of like-minded people. That has been the striking part of this ECG club success. It is the strength of leadership. I don't want to name anybody. It's the strength of the leadership which has attracted people with the same intention of learning and then helping out fellow students, fellow doctors, and finally the patients, ultimately the patients, and extending into charity, and also now gone into extending into making new teachers. So it is a movement which has been going on for the last 25 years, and we are so proud to be part of it. And it is the strength of the leadership that has made it possible. It is simply not anything else. And it's a collective efforts and sacrifices done by our Secretary General, our secretaries, our treasurer, and our core committee members who put in all their efforts when it comes to ECG Club without any reservations. And it's the utter simplicity of the vision and the mission. It is very simple and very straightforward, and it's ethical. So that has been the reason for the success behind this club, and I wish this club more success. And of course, we are the best part is that the club itself doesn't take any credit for it. You just saw that everything is going for charity. It's just that we are learning and then using it for charity. So definitely all this will be blessed by the Almighty, and we thank ultimately we thank sir for all his efforts and gathering us into a group like this. Thank you, sir.
Thank you, Dominic. Short and sweet as usual. So election of office bearers is a little bit of formality we have to undergo. So Dr. Ramesh.
So as he rightly said, for the formality's sake, let's now elect Dr. Chennappan sir as our managing trustee. Dr. Kader has proposed it. Dr. Vijay Kumar has seconded it. So he is elected as the chairman, the managing trustee. Vice President is once again Dr. Dominic sir. proposed by Jaykumar. Dr. Jayashree has seconded, so taken. Then Secretary General post is getting changed this year. Dr. Wilson. Dr. Grigori is proposed as the Secretary General. Dr. Chandramohan has seconded it. So congratulations, Dr. Grigori. Executive Secretary, Dr. Cherian. Dr. Cherian proposes Dr. Vijay Kumar as the Executive Secretary. Dr. Rajendran has seconded it. So congratulations, Dr. Vijay Kumar. You are welcome on the stage now. Oh, no, chair board, sir. Vijay Kumar. No, you become office bearer now. Treasurer, Dr. Vijay Kumar, Velai Raj proposes Dr. Sivakumar to continue as the treasurer. Dr. Mani Raj has seconded it. Excellent. Congratulations, Dr. Sivakumar. And then trustees. We have some trustees to go. By virtue of being the office bearers of the ECG Echo Club, the following people are already automatically become the trust members, ex officio trustees. That is Dr. Cheniappan sir, Dr. Dominic Rodriguez, myself, Dr. Grigori, Dr. Vijay Kumar, and Dr. Sivakumar are ex officio members. And other members are to be nominated. Anybody to propose? Dr. Anita Madam. Dr. Wilson, Dr. Cherian, Dr. K. Rajendran, Dr. R.T. Maniraj. They are all today get nominated as the members of the trust. Seconded by anybody? Anyone to second? Dr. Vijay Kumar, Dr. Kannan, they are all seconding it. So all these office bearers have been unanimously elected for the respective posts. And then we are going to pass some resolutions.
So the first resolution is to create a new position designated as patron of our club. So as you know, the Dr. Ramesh, who has been the founder secretary, and because of his not age, because of his seniority, and he is the first one who mooted the origin of the club. So he has done an excellent job as a Secretary General. So we try to designate, we give a new position as patron, and I propose Dr. Ramesh as the patron, the first patron of our club, Dr. Ramesh, and it is seconded by all the people. So he is going to be our patron of the ECG club. Usually the patrons will be the patrons. So they will be doing nothing, but Ramesh will not be a patron of doing nothing. So a patron will do everything as usual as Secretary General. So your name has changed, but your work has not changed. So it has been decided to collect 4,000 from the practicing doctors and 2,000 from the students towards actually to the donation of the ECG club to become the members of the ECG club for the year 23-24. It has been decided to conduct one hybrid meeting every month, preferably on the last Thursday of every month, subject to various factors prevailing at that time. So it has been decided to celebrate World ECG Day, as Dr. Ramesh mentioned, on the 21st May 2024 by doing free ECG by all our members for all their patients on that day. And of course, the conducting workshops for the paramedics, public awareness programs, and within that particular week. The order statement of the accounts for the financial year 22-23 submitted to the Income Tax Department was approved and passed by the general body. Yes, passed as. So all the resolutions passed as. So publication is given, permission is given to create a publication of the proposed books. And we thought because there is a lot of clerical work which is going on with a lot of communications we have to do with all sorts of the auditors, income tax department, and preparing the slides for the academic activities. Now this application is some membership application. We have to submit a lot of records. We thought we create one office manager to do all these jobs and the other related activities. So that so far we didn't have any person to do that. So I think we have been doing that, and it is now become more and more work to be done because of the expansion of the members. So the office member for the clerical audit to be appointed, and the salary of the remuneration for the office manager to be decided to be fixed by this general body.
Shall we take all the resolutions as passed?
Yes, passed.
Passed. Thank you. Yeah, we automatically we authorize our managing trustee to select his clerical staff and decide the remuneration for that, right? We take it as passed. Okay. Any other matter to be discussed? Any other members to say something?
Come and
Dr. Velayadraji say.
you can also ask.
Yeah, people online also can.
Oh,
Oh.
this is the donation, first donation we received for that year. Thank you, sir. Thank you. And you can also give some words of wisdom.
No, sir. Say something. I request Dr. Vijay Kumar to say a few words, the new executive secretary.
First of all, sincere thanks to our chairman and all the members selected as the secretary. Thank you very much. இங்கே வந்து என்னென்னா போஸ்ட்டுங்கிற பேர் தான் மாறும், மற்றபடி எல்லா சிஸ்டமும் அதே மாதிரி ஒர்க் பண்ணிக்கிட்டே இருக்கும். அதனால் இது வந்து ஒரு ஆர்னமெண்ட் மாதிரி தான், பட் எல்லா ஒர்க்குமே எல்லா வருஷமும் நடந்த மாதிரி நடந்துக்கிட்டே இருக்கும், கண்டினியூஸாக நடந்துகிட்ருக்கும். we will try our level best to do more than 2023. So every year we are going to increase put our efforts to make the academic programs very successful and public program very successful, and the patient charity program will be successful. We will do the best, sir. Thank you, sir.
Dr. Anita, madam.
Good evening, sir, and all respected senior colleagues on the table, and my dear friends. I seem to have missed out on so many things. Obviously, I've been very busy and never had the time or the inclination to turn the other side and see what the whole world has been doing. And now that I have a lot of free time, my main aim was to keep in touch with medicine. There are a lot of academic activities going on in Trichy. Why don't we also join them? அப்படிங்கிற ஒரு inquisitivenessல தான் join பண்ணேன். But every day I seem to be learning so much from you, sir. Thank you for sharing your knowledge. Even a simple cooking recipe, there was a lady who was who had been in TV for a long time, and she came and she was a little angry with me because I was demonstrating a microwave oven in my father's shop. நீ எப்படி இதெல்லாம் எல்லாருக்கும் சொல்லுவ அப்படின்னாங்க. I was quite surprised. And over the years, the knowledge and experience which you have gained, you have been sharing with all of us, and I pray to the Almighty to give you and your family and everyone of this club good health and happiness always. Thank you for yourself.
Thank you, madam. It is an honor to have you in our club, who is the senior most member, senior most physician of our Trichy, the dean of medical college, and also very great work done during the COVID times. So it's an honor to have you in our club, madam. Okay. Excellent, madam. Thank you, madam.
Anybody else? Dr. Saran? Would like to say something? Vanga. Anybody on online? Dr. Rajshekhar?
Sir,
Yes, anybody
good
else?
evening, sir.
Please, go ahead.
Sir, YouTube channel name, please.
We'll put the link subsequently. We are trying to, what the first activity you are going to do in that YouTube link will be to upload our all the conference lectures. That is the lectures of confusions in cardiology. We're trying to upload that as the first program of that YouTube channel. So what I request is to popularize this YouTube channel. So for every YouTube channel, people will say, subscribe, press the bell button, and keep for notification. So spread across your your friends, all the WhatsApp groups, because more and more subscribers we have, we can also generate some income from that YouTube channel to our ECG club fund. So what we are going to do is the first to upload all the lectures of our confusions in cardiology, so that you can spread across this and make popularize this club. Then of course our also we are trying to put something into public education programs, so that will invite not only the doctors but also the public. So only when the public come in, the subscribers will increase in number. So we're trying to put some public programs also. So many of our lectures will be uploaded there. The weekly lectures which we give will be uploaded there, and our past lectures will be also uploaded there. So we are trying to work on that. That will within 1 or 2 weeks, and it will be ready, and we'll be able to give you the link. And your job is to popularize that. That is your. I request all the members, offline and online, to popularize this channel, so that we'll get more and more subscribers. So you must not only see the videos, you must subscribe. You must, once again I tell you, press the bell button so that you get the notification. So more and more subscribers we want. We don't want people who are just seeing the lectures. We want people to subscribe to this channel. So the more and more subscribers we get some amount of advertisements on that, then we get some income to the club. So that is the main purpose, not only to disseminate knowledge, but also a small ultimate motive is there also, to get some more income to the ECG club. So we'll give you the link in subsequent weeks.
Thank you, sir.
Last one, I forget to say that because I'm expecting a Secretary General will announce that. Why we are recurring fund means because every month we have 80 to 86 patients as of now. We're getting free drugs every month, all are costly drugs. And apart from the drugs, free investigations, even sometimes admissions, all are free for our patients, 86 patients as of now. It comes around almost 1.3 to 1.6 lakhs per month. We are giving free drugs for all the patients. That's what we need money to give our charity purpose. It's not for gaining the money from our ECG club. Thank you.
There's ஒரு பெரிய addiction மாதிரி. You start liking it more and more. And more so that our students themselves who are able to give lectures on their own, brilliant lectures. I come to see one day Dr. Dominic sir, Dr. Kader, I think or Dr. Vijay Shekhar also, he took a class. எல்லாமே செமையா இருந்துச்சு. Thanks to you, sir. And Dr. Srinivasan, our own Dr. Muttumani. It is so nice that you have created a lot of excellent teachers yourself. ஸோ உங்கள் ஃபோர்த் மோட்டோவும் நல்லா செமையாக நடக்குது. ஜிஹெச்சில் வந்து நிறையா பேஷண்ட்ஸ் ஃபார் ட்ரக்ஸ் சேக் வருவாங்க. எவ்ரி 3 months வி கெட் பட்ஜெட் ஃபார் தெம். பட் அது ப்ராம்ப்டாக 1 monthல காலியாக போயிடும். அந்த ஏழைங்க முகத்தை பார்க்குறதுக்கே ரொம்ப கவலையாக இருக்கும். And it was a surprise to learn that you are supporting a lot of poor patients also. Keep up the good work, sir. Thank you, sir.
Online.
Anyone on online? Dr. Rajshekhar?
Sir, yes, sir. Good evening, sir. Good evening, all of you. And really, very much overwhelmed and spellbound. Just I want to make only one point. Sir, am I audible, sir? If a rain drops into the raindrop falling into a river, the raindrop loses its identity and it becomes a river. And if the river passes into the ocean, river loses its identity and become a ocean. So the ECG club is a ocean in which though every member is a raindrop, they are losing their identity and they become a ocean. And since the identity is not the matter here, and nobody is self-boasting themselves, that is the successful anchor of this club, and which I found very fascinating, and which is not present in anywhere in any association, whether it is our medical profession or any other profession. There is no ego, no self-boasting, whether it is Vijay Kumar or Ramesh or Girigiri or Sivakumar or Dominic sir. This is really the point to be learned by everyone who is here today, and that has to be continued forever. So once you lose your identity, you can become a ocean, and the ECG Aqua Club is a ocean of everything. Thank you, sir.
கவிஞர் ராஜசேகர் ஐயா அவர்களுக்கு மிக்க நன்றி.
For ECG and Echo Club of Trichy. So he is the one who get all our students, and he is bringing lot of members to ECG Club fold, and we thank him for being so nice to us and so friendly to us, so having so much of love and affection to us. So it's really great to have you amongst us, Dr. Rajshekhar. Definitely.
My
Thank
pleasure.
you. I've been telling so many years that he is our PRO.
For your YouTube channel also, sir.
Yes, yes. Yes, yes, please, sir. Please.
Okay, we will move on to the next agenda. Any concluding remarks, sir?
I just want to thank all the members and also the office bearers who stood with us actually in spite of our short-temperedness, So it's very difficult to work with us. Dr. Ramesh would have experienced it. Dr. Girigiri would have experienced it. So in spite of all my shortcomings, they are with me for so many years. So, but the only thing they failed us is to change me. Yeah. So I continue to be like that. But I thank them for tolerating me for all these years. My short outbursts when something is wrong, something is not good. So they are not taken into their hearts. They are not become a little bit discouraged. So actually they get encouraged. So that makes me do things more than what I am doing now. So, and also I thank all the members for taking it easy, whatever the little bit of comments I pass in each ECG interactive sessions. So they are not also is not taken into heart. They are taken into light-hearted way. So the main forefront is with Dr. Vijay Kumar. So he is the persistent receiver of all our good comments. So everything is taken easy. They are not taken into hearts. So that creates a very good atmosphere, a little bit easy atmosphere, little bit of enjoyable atmosphere. So actually the learning has become enjoyable, Learning will be actually is very good when it becomes enjoyable. So it should not be a burden and it should be enjoyable. That's why we conduct sort of interactive sessions and give some difficult questions and plus some comments so that it makes all easy and quite enjoyable. You also learn, you enjoy something. So that's the best way of learning. So I thank all the members and all the core committee members who are standing with me for all these years in spite of me, not because of me.
ஆக்சுவலி சார் நாங்கள் ரொம்ப அதை என்ஜாய் பண்ணுவோம் சார். நாங்களே நிறைய கேட்டு வாங்கி பண்ணோங்க. இந்த லிஸ்ட் நாட் கம்ப்ளீட்னு போட்டு அதை நாங்கள் ஆன்சர் பண்ணுற போதே தெரியும் அடுத்தது வாங்க போகிறோன்ட்டு. தெரிஞ்சுக்கிட்டே தான் வாங்குறோம். பட் அது சுகமான அனுபவம் சார் அது. We enjoy that.
Previous.
Yeah. Okay. The last part of the day, Dr. Grigory to propose the vote of thanks.
Good evening, friends. At this wonderful evening, I stand before to express my vote of thanks.
Before that, it is, I think, you give a big hand to Dr. Girgiri, who has been handling the all the important things in a very, very precise manner, I must say. The subscriptions, the delicate fees. So he does lot of work, you know. So it is not seen outside. So the main, you know, that the 4 hours, within 4 days, we got some 100 delegates, because he posted individually in each WhatsApp forum all our flyers, and he takes so much of trouble to tell others what the conference is about, the delegate fees about, and so on. So he's a silent worker, and very, very, I think it's a pillar of our ECG club, and very, very, very technically sound person. So he get a little bit upset when the other person is not technically sound. That is a problem with Girgiri. So when they are doing something wrong, he gets upset, just like I myself. So when the ECG you are not telling, I get upset. So when the other person is not technically so powerful, he gets a little bit upset. So he expect all the others to also technically so good. That's why he got the promotion of this year as Secretary General of our ECG club. And I expect him to do the good work he is doing. Thank you, Dr.
Thank you,
Girgiri.
sir. Thank you, sir. First of all, I thank our beloved chairman, Dr. MC sir, for his tireless hard work to build our club as a unique academic body in and around Trichy and teach all medicine updates for us till today. Thanks a lot, sir. Next, I wish to thank our vice chairman, Dr. Dominic sir, for his silent and motivating guidance throughout the year. Thank you, sir. I thank our Secretary General, my hero, my guiding force and well-wisher, Dr. Ramesh sir, for his excellent, wholehearted and sincere work towards the growth of our club. Thank you, sir. I thank our Treasurer, Dr. Siva sir, senior members and all our members for the excellent cooperation and guidance throughout the past 1 year and also in future. Thank you all. My special thanks to Mrs. Gayatri, Secretary of our sir, who helped me a lot in all our administrative process. I thank Mrs. Sun Pharma Coronary Division for sponsoring this meeting, and Julius and his team for audiovisual arrangements, and management of Hotel Oxina Lygon for their nice hospitality. Finally, I thank and also welcome all our new members who joined very eagerly with great expectations, and we will try to fulfill your expectations and request your kind cooperation throughout this academic year. Thanks to each one of you. Thank you.
Thank you. Good night.
Thank you and good night. We will disperse.